morning. Good morning, my dear future doctors. Good morning, Marilyn, Philip. How are you? How have you been doing? Thank you. I'm fine too. I'm well. You're fine. How it is in Lebanon, Marilyn? Is it getting better? Yeah, better. Okay. I'm glad to hear that. Here as well, we've got less than 5 cases each day, and a lot of people are getting well. So we've got really low amount of active cases. Okay, it's getting better. Yeah. Yeah, that is good. Hello, Sarah. Good morning. How are you? Hi. Well, we have finished all the 6 topics that are going to be included in the second midterm, as far as you know. So today and next Saturday, I'm going to make a review lecture, okay? So today I'm going to discuss with you first 3 topics, including CNS, cardiovascular, and kidneys. And next Sunday, we're going to discuss the next 3 topics, which will be hormones, drugs affecting blood, and the last chapter, gastrointestinal. And the next Monday's week, I don't know exactly the days, but you're gonna, can you please focus what? Yes, that is why I'm making this review, that I will focus on the things that you should stretch your intention on, okay? Yeah. Yeah, I know it's a lot. It's 10 chapters in the book. Yeah, I know it's a lot. So if you have read the book, that's a great thing that this PPTs and this review will gonna help you to revise everything you've read, okay? Yes. Okay, then we've got a lot to do, so I'm not gonna waste time. I'm just gonna switch my screen. Yeah, it's too much and a lot harder than the previous topics because it includes systems, but a lot more interesting and clinically important as for the future doctors. Okay, so let's start with the CNS. We'll just give it a second so you can. Are you able to see the screen? And the exam will be hard. Yeah, exam will kind of. Yeah, all of the topics will be on the exam. So yeah. But not a lot harder. If you do well on this midterm, I'm gonna think about example what's to. So I'm gonna choose not all of the topics, but some of the topics that I will share with you. Okay, not everything, just a lot. I mean, so I will pick some of the topics that I think are the most important, and that will be included in the exam. Yes, drugs for gastrointestinal are also included. Yes, last thing is also included. This is the 6th topic. Yeah, and next Saturday we're gonna review it. Okay, so CNS it is. Yeah, and PPTs or an order topics is quite different, but that doesn't mean anything. Okay. So we talked about this is not what this is was just for me, for you to let's say make clear how important it is neurotransmission in the CNS and how different it is than the autonomic nervous system. So this will not make a question. So, and I talked about the excitatory and the inhibitor pathways. This is also not included in your midterm, but just for the general knowledge, you should know that, okay? And this is glutamate, which are the examples of inhibitory and excitatory pathways, synapses. You might have that kind of question, okay? For example, you know glutamate and GABA aminobutyric acid, which is inhibitory mediator, okay? Yes, and sedative hypnotics. Yeah, you should know the difference between sedatives and hypnotics. And the barbiturates were the first drugs discussed by us. So pharmacokinetics is something you should you can skip, but the mechanism of action you should definitely know that. Okay, so the barbiturates interact with GABA alpha A receptors and enhance GABAergic transmission. It means inhibitory transmission. They have anesthetic whole properties as well, and they're used for the pre-medication as well because they decrease neuronal activity, decrease cause sedation, and for the endoscopic or colonoscopic procedures is very good. Okay. Yeah, and the examples are thiopental, phenobarbital, cyclobarbital, and all the barbitals. Okay, barbiturates, barbital, with the suffix, and thiopental is the exception for that. So they are effective as sedative and hypnotic, but you should remember that they don't have anti-anxiety properties. Okay, they are not used as anxiolytics. Okay. So we talked about that they cause depression at the CNS. They do not raise the pain threshold, so they don't have analgesic properties. That is why when we talk about anesthesia, we are not going to use them as a sole agent, okay, with opioids together because they only cause sedation, hypnosis, not analgesic properties. Okay, remember that. Not anxiolytic and not analgesic. Yeah, enzyme induction, you know, the cytochrome P450, they undergo metabolism in the liver, so that is why they have a lot of drug-and-drug interaction in between. Therapeutic uses you definitely should know, okay? For anesthesia, as I said, intravenous to induce the anesthesia, premedication as well. Phenobarbital is used also for the tonic-clonic seizures. When we're going to talk about epilepsy, we're going to meet them again, okay? Status epilepticus and eclampsia, which is a hypertension during the pregnancy, okay? Also with children who have temperature-dependent seizures or febrile seizures, where they appear when the temperature is more than 38 degrees of febrile. That is right. Okay, and also it depends can depress cognitive performance in the children if they're using it for the epilepsy. Okay, anxiety. You know that they don't relieve anxiety. They are mild sedatives. That is why it might be helpful with the complex therapy, with the combination of the anxiolytics together. So they have replaced benzodiazepines. They have been replaced by benzodiazepines because of the anti-anxiety properties. Okay, benzodiazepines are more common to be used. Okay, pharmacokinetics, as I said, this is just yeah. I don't know if I will make questions about this, but read it. Okay. So you should know that important is that they cross the placenta barrier and they can depress the fetus. So when we're using it during eclampsia or pre-eclampsia, it means the hypertension during pregnancy, you should also think about that they also can depress the fetus. So fetus heartbeat monitoring should be really close and yeah, continuous. So their metabolism liver, as I said, was cytochrome P450, and that's the reason of the drug-and-drug interactions. Adverse effects you should definitely know. Okay, drowsiness, impaired concentration, physical fogginess because sedation again, and hangover is dragging hangover and feeling tired after the usage. So that is why prescribing this drug before the bedtime is a better thing because in the morning they will have less hangover, occasional dizziness, no nausea, and so on. Okay, less of the drug hangover. Precautions that because they interact with many drugs, they are contraindicated also with the patients who have acute intermittent porphyria. Okay, this is something you should know with the red. Yeah. Okay. So also they might cause tremors, not because this is quite illogical because they are used for epilepsy, but they are the reason of the tremors. If they are the treatment is ceased promptly, okay, the dosage should be tapered for a period of the time, and then the cessation should take place, okay, because they've got withdrawal associated with opiates and can result in death, okay, if they use and can come together, okay. Seizures, delirium, cardiac arrest also can be at the side of the physical dependence, okay. And about the poisoning, yeah, what are the symptoms of the poisoning? You should know that. And what will help? Artificial respiration if we've got depression of the respiratory rate, and the stomach rinsing out, and also hemodialysis if the barbiturates are already concentrated in the blood, okay? And alkalization of the urine to increase their clearance and excretion, okay? So then benzodiazepines. We said that benzodiazepines are the ones that BZDs that substituted the barbiturates, okay, in the CNS treatment as a sedative, hypnotics, okay. Yes, BZs, and they've got two receptors, and again they increase the frequency of the channel opening produced by GABA. So again, inhibitory receptors here, and that is I'm skipping again because it's not going to be in the midterm. So they reduce anxiety because not like barbiturates. They induce anxiety and are good anxiolytics as well. They cause sedation and hypnosis. They've got anterograde amnesia, but it's equally important during the anesthesia. Do not remember the traumatic experience from a surgery. So this is also important. Anticonvulsants, they are used as the anti-seizure drugs as well, like just like benzodiazepines, just like barbiturates. And muscle relaxation is also one of their action. They cause inhibition in the spinal cord, and as a result, they cause the abolition of the reflexes, and as a result, immobilization. Okay, muscle relaxation. Yeah. Yeah, they also are able to cause addiction, and the more usage is quite frequent. So that is why the treatment should be monitored with the physician. Yeah, and the longer acting agents include clonazepam, lorazepam, and diazepam, and those are prescribed for the patients with anxiety, okay? For those that require prolonged treatment for the long period of time, the longer acting agents are preferable. And anti-anxiety effects, they are less subject to tolerance than the sedative and hypnotic effects. So in the mental disorders like anxiety, they are frequently used because the tolerance develops much, let's say, much quicker to the sedation and hypnosis than to anti-anxiety effects. Okay. Yeah, tolerance occurs more than 1 to 2 weeks, and the cross tolerance with the FM. Okay, have a drink should not be prescribed with this drug because it shows a decreased this tolerance is associated with a decrease in GABAergic receptor density, so they don't have any substrate to have the influence of, so that's why the tolerance occurs very quickly in about 1 to 2 weeks. And chronic disorders like alprazolam is effective for short as well as for long-term treatment, and it might cause withdrawals. as all of the benzodiazepines. Therapeutic use is also important, just a list. Yeah, they are used for muscle disorders like skeletal spasm, muscle strain, or spasticity caused by multiple sclerosis, and some of the cerebral palsies. And the post-neurosurgical patients also are prescribed benzodiazepines because they've got specific hemiplegia or paraplegia, so that is why they are prescribed to decrease the spasticity of the muscles. And yeah, amnesia, as I said, they are very good for the pre-medication. They substituted the barbiturates for the endoscope for the short invasive procedures like endoscopy, like bronchoscopy, colonoscopy, and so on. And even dental procedures as well, and the angioplasty. Okay, remember. And midazolam, that is used for to cause the conscious sedation. You remember that for anesthesia, which was the subject of the previous midterm. That the conscious sedation is when the patient is conscious but not fully aware of what is happening, okay? Because she is sedated and it's not the obstacle for the procedure to perform, okay? Midazolam is that good for that reason, okay? For induction of anesthesia as well. For conscious sedation and induction of the anesthesia. Yeah, and again, as I said, they are used as anti-seizure drugs like clonazepam, the certain types of epilepsy, and diazepam and lorazepam for the quick cessation of the epileptic seizures and for the status epilepticus. Status epilepticus is the a series of the seizures in between the patient does not regain the consciousness, okay? Due to cross tolerance, they've got Florida, so this one I will include, okay, just it. Sleep disorders also are benefit from the usage of benzodiazepines, so long acting. I advise you to look into the red things or underline things, so that will help you to stretch your intention, okay? Long-acting flurazepam, intermediate-acting is temazepam, and short-acting is triazolam. Okay, maybe the question from that. Okay then. So this I will notice this like this. This is a two yeah. So I will you can skip it. Absorption and distribution as well, just for your reading. But you should also know that just like barbiturate, benzodiazepines also can cross the placenta barrier and may depress the CNS of the fetus, okay, and of the newborn as well. So nursing infants should not, nursing mothers who've got period of lactation or nursing infants should not take this drug as well, or should be advised beforehand that the drugs can be through the milk transported to the child and might cause the depression of the CNA and yeah, depression. That is it. Okay. And dependence also might develop psychological as well as physical dependence, and with abrupt discontinuation, as I said, causes withdrawal symptoms like confusion, anxiety, agitation, restlessness, insomnia, tension, and seizures. Okay, so that is why the dose should be tapered for a period of time, and the cessation should happen after that. Okay. They have long half-lives, and withdrawal symptoms might appear in a number of days, okay, because they have a long half-life.
Doctor,
Yeah,
sorry, but you are reading all the slides.
yeah, but I'm stressing the attention on the red things, okay? Just summarizing.
So, Dr. Ali, we concentrate on the red points that are on your presentation
Yes,
for the
yes,
midterm.
yes, red things and the underlying things, okay? Not
Okay.
just that, but I said the pharmacokinetics will not be as let's say as detailed.
Because like every presentation is about like 100 slides, and you know that we are not in the mood at studying that much, and we already studied the book. That's why.
Okay. Okay.
So please concentrate on the main point.
Okay. I said that therapeutic uses and general description will be important. Okay. And also the names of the drugs. You should differ from which group they are. Okay. That's it. Okay. So therapeutic uses and yeah, general description, not pharmacokinetics, as I said. It will not be as detailed as in the book. Just from the slides, okay? In the slides, I don't have a, yeah, I have just shortly summarized it. That is why slides are important, okay?
Okay, thank you.
Okay. So, therapeutic uses, adverse effects, and the drugs, okay? You should differ from which group they are. Adverse effects are important. I cannot skip this one, okay? Yeah. No, so they've got cognitive impairment, triazolam dependent develops very quickly, and morning insomnia because they also got hangover effects, daytime anxiety, amnesia, and confusion. So that's it. So with the red things, yeah. Flumazenline is the drug that antagonizes benzodiazepine receptors. So this is what you remember from that. And if we've got the case of intoxication with the benzodiazepines, flumazenline should be injected intravenously, okay, in order to gain the quick effect and in emergency situations, okay. Which drug should be used in case of benzodiazepine intoxication or overdosage? Flumazenline is the drug, okay. Yeah, you should know that as well. And these are the newest. This drug also acts on the benzodiazepine receptor family, but it's not quite a benzodiazepine. It has a few withdrawal symptoms. It's more safe to use for the therapeutic treatments, and also undergoes metabolism in CIP. So this one I will not say. Zolpidem, Zaleplon, and Esopiclon. They are also the ones that influence. They connect with the benzodiazepine receptors and cause sedation and hypnosis. Okay, but not from benzodiazepine group. You should know these drugs as well. Just the names, just a list of it. Okay. So I'm skipping this one. Also, the drugs, antihistamines. We said that antihistamine is one of the major side effects is sedation. So in this case, we can use antihistamines as sedative agents, okay, because of their sedative properties, like diphenhydramine, hydroxyline, doxylamine, and so on, okay. And ethanol. There is yeah, a lot in the book. Just ethanol is this short in my PPT, so you should read from here. So yeah, alcohol withdrawal treatment includes benzodiazepines. Carbamazepine is effective for the compulsive episodes during withdrawal. Okay, white fever, what is called. And drugs for alcohol. Just a list of the drugs. What are the possible uses? And naltrexone not produce adverse effect, but disulfiram produces aversive effects. It means that when the person is taking alcohol, it has got into the reaction and cause them confusion, flushing, and unwanted effects, so that the drinking is linked psychologically with the bad effects, so they quit in this case. Right? And acamprostate also are used for the supportive psychotherapy with alcohol abuse. So that was it with sedative hypnotics, not anxiolytics. And now about Parkinson. So this is an important topic. This is I will skip. Yeah. Yeah, you should know where it happens in suspension nigra and corpus creatum, where dopamine secretion is decreased, is the reason of the Parkinson's disease, just like that. So, secondary Parkinson, what is it? So, for drugs like phenotazine and haloperidol can cause this tremors, and that is why these are the drugs that should not be used with a Parkinson's disease because they make it more severe. And viral encephalitis and multiple vascular lesions as well, secondary Parkinson. Yeah, as I said, this is I will skip. This is I will skip. So the first group of drugs is the levodopa and carbidopa, and the mechanism is important for you to understand. They are the precursor. Levodopa, L-dopa, as you can see here, is the precursor of the dopamine. So if we supply the patient with the precursors, it means we increase the actual dopamine amount in the synapses. So what the insufficiency of dopamine is the reason of development this tremor. So dopamine is less in the synapses. It cannot react with its receptors, or it is uptaken, or it is broken down by MAO. A and B as well. B in the central nervous system, A in the periphery, and COMT. This is the also that breaks down dopamine. Okay, so we can substitute. So there are the first treatment, we can substitute precursors and increase dopamine level, and we can use dopamine receptor agonists to gain the same effect, or we can block the MAO-A, MAO-B, and COMT, and also we can block reuptake. So the drugs, the mechanism of action of these drugs is just like this. So, as I said, first drug is levodopa and carbidopa. They are metabolic precursors, and dopamine itself is easily broken down in the periphery, while levodopa is not so much. So it can, when it's given with carbidopa and levodopa-carbidopa in combination, much of the concentration enters the CNS and we've got a good effect. But if levodopa is solely used, the majority of it is broken down in the periphery, okay? And also high dosage of the levodopa causes a lot of side effects, and when we use it in combination with carbidopa, the side effects are decreased, as well as the dosage needed for the to be given for the therapeutic effect. So that is why they are used usually in combination, okay? So this is the mechanism they do. They inhibit TDC, and this carbidopa inhibits TDC, and the carbon inhibits COMT. So carbidopa, levodopa, and entacapone as well can be helpful to decrease the peripheral breakdown of the levodopa and decrease the dosage and consequently decrease the side effects. Yeah, and this is the side effect: nausea, vomiting, cardiac arrhythmias, and hypertension. Okay, remember this side effect of the levodopa: nausea, vomiting, cardiac arrhythmias, and hypotension, decrease in the blood pressure. And all these side effects are much less and with the usage of carbidopa and entacapone as well. This one I will not give you. Action. Yeah, you should decrease the rigidity, tremors, and palpitation. So therapeutic uses, as I said, Parkinson's disease. I will not talk about this one. And this is important. Levodopa should not be taken on an empty stomach because the neutral amino acids are competing with absorption. So the incomplete absorption might occur. So that is why it should be taken only on an empty stomach, okay, before the meal, okay. Withdrawal from the drug must be gradual because the side effects are very severe if the cessation of the therapy is the prompt, okay. Peripheral effects are anorexia, hypertension, mydriasis. So this is not important. Yeah. Anorexia and brown. This one you should know. Saliva and urine are brownish color because of the Melanin pigment produced from catecholamine oxidation. Okay, brownish color. Which of the drugs might cause this? So this one could be the question. And mydriasis. So here is mydriasis as well. Adverse effects for the CNS: visual, auditory hallucination, involuntary movements, mood changes, depression, psychosis, anxiety, and so on and so forth. Okay, this one I will not include. This one I will. So it increases in psychotic patients. Levodopa increases symptoms, that why it should be used carefully. And also during glaucoma, it increases intraocular pressure, and it is not recommended. And also in cardiac patients, cardiac arrest is more frequent, and in psychotic patients, also they're generally contraindicated with antipsychotic drugs because psychotic symptoms are worsening. Okay, and also these drugs, antipsychotics, can produce secondary Parkinsonism, as I said, and also haloperidol is able to produce secondary Parkinson's. That is why they are contraindicated together. Okay, selegiline and rosagiline. So they inhibit MAO type D. It means they inhibit centrally acting MAO, not in the periphery. Okay, which also breaks down norepinephrine and serotonin. So it's altogether they increase dopamine levels in the brain because the breaking down of dopamine is less. Okay, so got accumulation in the synapses, and that's it for that. So you should know this. Selegiline and rosagiline inhibit MAO-B, while tolcapone inhibits COMT. Okay, this is also carbidopa, levodopa we said, and tolcapone not just inhibits COMT in the central nervous system, but also in the periphery COMT. Okay, that's it for that. So this one I will not. This one I will not. So here, it reduces the wearing off phenomena seen in the patients who are on combination treatment of levodopa and carbidopa. So this one, and entacapone and tolcapone together. This is what you should know that. This is not adverse effects. Hepatic necrosis. You should know about tolcapone. It causes fulminating hepatic necrosis. Okay. And then, as I said, we can either substitute dopamine or we can use the dopamine receptor agonist in order to cause the same effect. Okay, like bromocriptine, propinerol, pramipexole, and rotibine. Bromocriptine is the most important from the all this. Okay, and apomorphine is also used for the severe stages of the Parkinson. Okay, when other therapies are shown to show intolerance are not effective after all. That is all. About bromocriptine, you should know that current mental problems and psychic patients got a lot more worsened symptoms, and cardiac problems worsen, and worsening of the vasospasm. So that is why with the peptic also with the they are not used frequently. Okay, and the bromocriptine is a drug that causes pulmonary and retroperitoneal fibrosis. Okay, pulmonary and retroperitoneal fibrosis. Apomorphine, I said. This one I will not include. Bromocriptine as I promised. And amantadine antiviral drug that is also used for the Parkinson, okay, because the restlessness and also how to say dopamine release. If dopamine release is maximum, amantadine has no effect. But if we've got decreased dopamine release and there is still the free receptors that they can how to say have influence on, and the amantadine will be beneficial in this case. So just that, and amantadine is the only antiviral drug used for the Parkinsonism. And the antimuscarinic agents like benzotropine, just benzotropine, okay. And they interfere with the gastrointestinal peristalsis and are contraindicated with glaucoma, prostatic hyperplasia, and pyloric stenosis. Okay, indications. And these are all the summary of the side effects. As I said, levodopa, carbidopa, side effects, you should know. Therapeutic uses, side effects, and the drugs, okay? I am not asking you pharmacokinetics and dynamics and so on. Just what the things I've stressed. For example, they should be taken on an empty stomach and just things like that, okay? I am not asking you about cytochrome 450 system, their interaction, and so on. So levodopa, carbidopa, they cause nausea, vomiting, anorexia, drop of the blood pressure or hypertension, and stools and brownish color, as I said, and also lacrimation and sedation and depression is also one of the side effects. Entacapone and is constipation, and tolcapone, as I said, this is brownish color stool. This is causes fulminant hepatic necrosis, so very hepatotoxic is tolcapone. And selagin result again nausea, vomiting, confusion, insomnia, and sedation and retardation as well. And bromkriptine was the one that causes cardiac and pulmonary fibrosis. Okay, cardiac and pulmonary fibrosis for bromkriptine, and worsens vasospasm as well, and worsens cardiac symptoms. Okay, and those are for pramipexole, they hypertension, sedation, depression, anorexia, daytime sleepiness, and nausea. Like anticholinergic ones, we know this one: constipation, urinary retention, inability to focus, psychoplegia, and the dryness of the mouth, of the eyes, and of the skin. Okay, that is it altogether. So now let's talk about epilepsy. This is I will skip because I will not ask. This is also I will skip. Okay, this one also I am not gonna ask. I am not gonna ask. Yeah, this one I'm gonna types of seizures. Because you'll have a case and you should define which kind of a seizure it is and what drug is preferable for this kind of seizure. Okay, so you should know the types and the drugs for what kind of types are better. Okay, what kind of drugs are preferable for certain type of seizures. Yeah, so yeah, makes a lot of time. We've got, here's a scheme which will help you to remember, okay? We've got topiramate, we've got carbamazepine, oxymazepine, mazepine, okay? Which affect on the sodium channel opening. We've got levetiracetam that affects the excretion of the glutamate from the presynaptic vesicle. It acts levetiracetam affects the stabilization of this and stabilizes the membranes of the vesicle SV2A. Topiramate, you can see here, topiramate is underlined with the orange. It means also affects not here and here as well sodium channels as well as calcium channels, lamotrigine of calcium channels, gabapentin, pregabalin, and they also block the presynaptic potentials. As well, we've got here an MDA blockage by felbamate. We've got valproic acid and zonisamide that act on the T-type calcium channels. This is what you should know: what kind of channels they act and what is the mechanism of the action. Okay, benzodiazepines and barbiturates, they said they are GABA amino receptor and agonists, so GABAergic ones that increase inhibitor potentials. We've got tiagabrin that decreases the reuptake of the GABA. Tiagabrin increases presynaptic synaptic cleft GABA amount because the reuptake is blocked, and also vigabatrin, which decreases the breakage of the breaking down the GABA. Okay, GABA is an enzyme that breaks down the the GABA. I think I've listed all of them. Side effects like carbamazepine or carbamazepine. The most major side effect is that they decrease sodium. Okay, hyponatremia. Vigabatrin is the how to say cycloplegia and also blurred vision as well as sedation. In lamotrigine, we know hirsutism is very common. Lamotrigine and phenytoin. Remember, hirsutism is the unusual hairiness in the females and as well as the males. Okay, and also dizziness, cycloplegia, inability to focus, and some antimuscular and enlargement of hyperplasia of the gingivas. We should remember this. Lamotrigine and phenytoin causes hyperplasia of gingivas. Okay. While topiramate and zonisabit cause the weight loss and confusion, mental confusion, and valproic acid causes not like topiramate, but it causes thinning of the weight, and gabapentin and pregabalin peripheral edema is very common. Valproic acid and felbamate are highly hepatotoxic. Those that act on the T type of calcium channels are very hepatotoxic, and felbamate is the one that causes aplastic anemia. Okay, so this is just a summary of the side effects. You should remember like this. Okay, and here I have discussed drugs one by one. You should know the mechanism they act. It means which receptors they act, on which kind of type of channel they inhibit, and enzymes they inhibit. Okay, just the mechanism, and that's it. The side effects as well. Okay, mechanism and side effects. Okay, and what type of seizures they are used for. Again, therapeutic uses. So that's it. Yeah, I will skip this one, but you cannot skip this one, okay? And levetiracetam, as I know, it's vesicle proteins, and disrupts and interacts with the vesicle electrocytosis, okay? And that's it with the first thing. Okay, you should know the therapeutic uses, you should know the mechanism of action, side effects. Okay, these three things that I will mention, I will include in the midterms. Okay, now let's see the other two or four. Yeah. Okay. Okay, sorry for that. Yeah, psychosis will, I will not ask the classification of that, but you should know the difference between all of that, okay? Neurosis is one. I think for the case, obsessive compulsive, and post-traumatic, hysterical, and so on. So pathophysiology is not clear, but we know that monoaminergic deficit like serotonin, like noradrenaline is also the reason for that. So, and this is the classification you should know. Antipsychotic drugs. Antipsychotics are neuroleptic, atheractive, major tranquilizers. Okay, antipsychotic used for the functional psychosis and schizophrenia. Anti-anxiety drugs are anxiolytic, sedative, and minor tranquilizers used for anxiety and phobic states. This is what you know, what you should know. Antidepressants, they have for depressive illness, phobic states, obsessive compulsive behavior, and anxiety disorders. Anti-manic drugs, they are mood stabilizers. They control mania and breaking the cyclic affective disorder. And psychotomimetics, which is psychedelic, psychodyslipid, and hallucinogens, used to produce psychosis-like states. Majority of drug abuse like LSD and cannabis. Okay, so you should know the difference between tranquilizer and sedative. Okay, antipsychotics. No, okay. I will not ask this one as well. I will not ask this one. Yeah, classification you should know, okay? Anothiazines, chlorpromazine, and so on, butyrophene, haloperidol, and like this. Tioxanthis, fluoxetine, and atypic antipsychotics, this one you should know, clozapine, risperidone, and so on. This is the classification I want you to know. First generation, you propose that the target is the dopamine 2 receptors and high potency and low potency. I will choose the drug which one is for this, which one is for that, okay? I will do it like that. And you should note that low potency ones doesn't just act on dopamine 2 receptors, but also have alpha adrenergic receptor. Alpha adrenergic agonist, it means that it causes hypotension, okay? It causes hypotension. Remember, decreasing the blood pressure, especially when the prone position from the horizontal to vertical position. And also cholinergic effects, which includes dryness of the mouth, blood vision, urinary retention. Also histamine effects, sedation, and the weight changes in the weight loss or weight gain can be common with the use of low potency first generation topicals, okay? And here the second generation atopicals, which they just don't act on dopamine 2 receptors but also on serotonin receptors. And the clozapine is a drug you should remember. Clozapine can cause serotonergic effect as well as can cause alpha-adrenergic and histaminergic, or it has all three of them. And it causes severe agranulocytosis, which is the important side effect you should remember. If there is a case with agranulocytosis, you know which drug to blame, okay? And glucose increase, lipid increase, and weight gain is common. So like olanzapine and clozapine as well. And sedation and weight loss is for the this one yellow ones, and hypertension because of the alpha adrenergic ones. Okay, this is what you should remember. I will not say this one. So this one you should know: dopamine or receptor serotonin blocking activity in the brain, both of them. And which are the positive and negative symptoms? You should know that as well. And clozapine, you should know that ameliorates negative symptom more, so that is why it's more frequently used. Okay? And yeah, what are the extrapyramidal effects? Dystonias, Parkinson-like symptoms. This is what you should remember as well. Second generations, they have lower incidence of extrapyramidal symptoms. That's why second generation is more frequently used today, okay? And this is, you should know, all of them exhibit antiemetic effects, all of these drugs, except for aripiprazole. So exceptions you should know as well, because aripiprazole is a partial agonist of the D2 dopamine 2 receptors, and it blocks the dopamine 2 dopaminergic receptors and doesn't have antiemetic effect, okay? It's a partial agonist. Which one is partial? Aripiprazole. Anticholinergic effects, as I said, all of them include the blurred vision, dry vision, except clozapine, which increases salivation. So a lot of exceptions for the clozapine, okay? Remember that as well. This one I will not. Yeah, chlorpromazine is used for the treatment of insomnia and hiccups. This is important. And risperidone, haloperidol are for the Tourette's tics as well. You should know this one. If I have a case, you should know risperidone and halperidone will be the drugs used for that. Okay. In this midterm, there will be a lot more cases than the previous one. Okay, so be prepared for that. And risperidone and aripiprazole also for the secondary autism, to manage the autism and hyperactivity syndromes as well. And side effects is that you should know what a tardive dyskinesia means and what is the drug that causes it. Haloperidol, risperidone, and so on. And blind kidney movement. You should know that. Extrapyramidal effects are minimized by the administration of anticholinergic drugs. Remember that benztropine antagonizes extrapyramidal side effects. Okay, if we have the patient with toxicity with high rate of extrapyramidal drug, what is the drug to use? Benztropine. Remember, benztropine with extrapyramidal effect. Okay, and tardive dyskinesia is irreversible, and postural hypotension is a cell because of alpha-adrenergic abilities, properties. The patients might develop postural hypotension. Okay, and dentists should be especially aware of that and should advise patients to slowly sit up from the reclining position. Okay. Antipsychotic malignant syndrome. Yes, this is what you should know. Discontinuations of antipsychotics, dantrolene and bromkriptine. Remember bromkriptine that causes the cardiac and pulmonary fibrosis, okay, and vascular peripheral vasculitis. So they are administered for antipsychotic malignant syndrome. Okay, this is also the case. Hypersensitivity to agranulocytosis. As I said, clozapine is the drug for agranulocytosis. Remember, clozapine, agranulocytosis. Yes, agitation, aggravation. So this is just antipsychotics worsen the mood, and suicidal behavior is so common. I will not ask this one. Yeah, I will ask this one. The mood stabilizer is the for lithium salt, like mania and bipolar syndrome, and I will ask here. Diabetes insipidus that is caused by the lithium can be treated with amyloid. Okay, if the patient is long-term lithium treatment and they develop diabetes insipidus, amyloid is drug of the choice. Remember. But in this case, thyroid function should be monitored because amyloid contains iodine in itself, and we will discuss it with the cardiac effect. This one I will not include. Yes, this classification you should know. Yeah, this will definitely help you. Yeah. I will skip this one. So we've got serotonin receptor reuptake inhibitors, we've got norepinephrine reuptake inhibitors, we've got MAO inhibitors, and serotonergic norepinephrine inhibitors. So the first group of drugs was serotonin reuptake inhibitors, citalopram, and so these drugs you should know. Yeah, like this. And what you should learn here and the mind. Fluoxetine, sertraline, and thyroxamine are used for obsessive compulsive disorder, while fluoxetine is for childhood depression approved. Okay, not many drugs are approved with the children, so this drug is the exception. Fluoxetine, remember that one. Yeah, I will not ask this. Yes, side effects you should know. Serotonin. What is the signs of the serotonin syndrome? You should know that. So hyperthermia, muscle rigidity, sweating, microns, okay? And the other group, serotonin and noradrenaline reuptake inhibitors, both of them blockers. Just the examples of that. I will not include that. And we've got here typical antidepressants. Ibuprofen and mitrazolam will be the drugs you should remember. Okay, there are a lot of them in the book. Just these two I'm gonna ask. Side effects and for the smoking. Okay, and mirtazapine is alpha-2 receptor inhibition, so it did not cause anti-muscarinic side effects and does not interfere with sexual function. This is important consideration, okay? So the patient who already has impaired functioning, which drug will be a drug of choice, okay? Mirtazapine in this case, okay? And appetite and weight gain is common. I will not include this drug, I promise. And yeah. That's it. It's recycling. So last thing is recycling. Amitriptyline, amoxapine, and so on. Amoxapine, you should know that blocks dopamine 2 receptors as well as certain receptors, both of them. I will not ask this one. So slow withdrawal is you definitely required to minimize the discontinuation syndromes. Okay. Yeah. Here. Amitriptyline tricyclic antidepressants are often used to treat migraine, headache, and chronic pain like neuropathic pains. Okay, remember there is also a case for that. Okay, and here we have imipramine that is used for the control bed or wetting in children. Okay, also the case. I will not use it. Yeah, here. Adverse effects include blockage of the muscarinic receptors and aggravation of narrow angle glaucoma. So with the narrow angle glaucoma, you won't use. What is the contraindication of the tricyclic antidepressants? You will know. Narrow angle glaucoma. Okay. So we've got MAO inhibitors in here. We talked about MAO inhibitors when we talked about Parkinson's, like Pharmacology, and so they have amphetamine-like stimulant effect. They could reduce agitation and insomnia. That I will not include. So you should know that selegiline was the first antidepressant available in the transdermal delivery system, long-term treatment, long-term patches. Okay, transdermal patches. Selegiline. This is what you should remember. And here we got allergies. Here we got environment. Include this one. I will include this one as well. Yeah, hypertensive crisis for the tyramine caused this one you should know. And the patient should avoid tyramine containing foods. And that's it. Anxiolytic drugs. Benzodiazepines I will not say because I said what I'm going to talk about them. Yes, and these are the therapeutic uses. Panic disorder, generalized anxiety disorder, social anxiety disorder, performance post-traumatic stress disorder, and compulsive and phobia. Okay, this is all I'm going to do. I said I will not. Okay. Yeah, I said all that. So boost period. What I will ask about this one. Oh, I won't ask about this one as well. Okay. So that was it with the central nervous system. Okay, I'll be back in 10 minutes and let's discuss cardiovascular and kidneys, okay? If you are unable to, yeah, okay, Yusuf. Okay, let's back to our presentation. Do you see the screen? Hello there. Do you see the screen? Yes. Thank you, Madeline. Thank you, Philip. So, with hypertensive, what I want you to stress your attention that this is not. Yeah, first line therapy is always diuretics, and especially for those patients who have congestive heart failure. Okay, if there is a case with hypertension plus congestive heart failure, pulmonary edema, so in this case, is always will be the diuretic. Okay, first line treatment diuretic. I will not include this one. I will not include that. Yeah, diuretics I have as drugs affecting kidneys, so I will not press my attention. I will talk about that later. For just that potassium sparing one is amyloid triantrum and spironolactone. And about spironolactone, I want you to remember that it decreases the morbidity and mortality linked with cardiac complications. Okay, remember this one. Beta blockers decrease the output. Okay, decrease the cardiac output, reduce blood pressure and heartbeat as well. Okay. Then are especially good with the myocardial infarction patients. This is what this is all. And this is the AC inhibitors. You should definitely note that the difference between AC inhibitors and ARBs that affect the prostate. They have also bronchiectasis effect. Also, they affect the breakdown of bradykinin. They're responsible for the breakdown of bradykinin, nitric oxide, and prostacyclin. So they are vasodilators, and the ARBs don't affect bradykinin. Okay, just AC inhibitors. And the side effect profile is all the same with ARBs and AC inhibitors, but more severe with AC inhibitors. Okay, and they also decrease aldosterone, the preload, as well as alcohol. Side effects will be, yeah, both of them are, all the sartans are here. Yeah, side effects. Dry cough is the major side effects of cough for ACE inhibitors, ARBs, and all that are linked with the angiotensin aldosterone system. Okay, cough is the most severe side effect, but the most severe is with ACE inhibitors again. Angioedema, because they move the bradykinin, which won't be in case of the ARBs because they don't affect bradykinin. Okay, hypotension and hypokalemia. Now, all ARBs are alternatives, as I said, angiotensin 2 receptor blockers, sartans, okay? Sartans, and they don't have bradykinin levels, and the side effects are lower than the renin inhibitors. The only drug aliskiren. And what you should remember that hyperkalemia is often met with patients who are on both on ARBs and aliskiren altogether. Okay, remember side effect hyperkalemia. Calcium channel blockers, we're going to talk about the verapamil and diltiazem when we're talking about arrhythmias. So these drugs are not just antihypertensives, but also anti-arrhythmic drugs as well, and also are used for the migraine as well. Remember that? Yeah. Side effect constipation is for verapamil. This is what you should remember because I've got question medication linked with side effects, so you should know that constipation is what verapamil causes, dizziness, headaches as well, and nifedipine also causes gingival enlargement. You should know that too. Alpha-adrenergic I talked about them so much. Prazosin and all the zosins are the examples of these drugs, and the most severe side effect is orthostatic hypotension. Remember, postural hypotension with alpha adrenergic receptor blockers. There will be two questions about that, so remember please. Orthostatic hypotension will prazosin, trazodone, all the zosins, and alpha receptor alpha blockers. Okay. And yeah, they're prescribed with beta blockers like propranolol and diuretics. And reflex tachycardia is most common syncope. Okay, first dose syncope for alpha blockers. Remember, okay. And also the tamsulosin alpha receptor blocker is used for benign prostatic hyperplasia. Okay. And that alphabet I will not include, and clonidine I will say just the side effect, okay? Adverse effect sedation, tremors, and constipation, okay? And it causes withdrawal when cassation occurs promptly. And about this, yeah, just you should know that it's can be used for hypertensive pregnant women. Okay, if the patient is pregnant, alpha methyldopa is the drug of the choice with if concept comes. Okay, and vasodilators like pillows and monoxidil. I will not include this. I will not. So this one. Pregnancy-induced hypertension is controlled with hydralazine alpha in the previous drugs, as I said, and the lupus-like syndrome, which is the drug to cause it, hydralazine, lupus-like syndrome. Okay? Minoxidil is also for malignant precardia and reflex tachycardia and hypertrichosis. Okay, remember about the minoxidil, hypertrichosis. Emergency, I will not. Emergency cases, you will use sodium nitrochloride. If we have a case with hypertensive crisis, yes, sodium nitrochloride. And the reason they are not widely used because of the cyanide toxicity, okay, the product. And labetalol is for emergencies as well, intravenous bolus. Remember, labetalol, beta blocker, beta and alpha blocker all together. And yeah, that's that. And phenoldopham also used for the intravenous emergency situations and contraindicated during glaucoma. That's it. You should know that. Nicardipine, calcium channel blocker like verapamil-diltiazem. Nicardipine is for the intravenous infusion. Remember, for the hypertensive emergencies. Okay. And resistant hypertension, I will not discuss. Okay. Pregnancy, we said that we should never ever use ACE inhibitors, ARBs, aliskiren, renin inhibitors, okay? Never ever use with the pregnant woman, this one. And sodium nitroprusside, which is used in emergency, also contraindicated during pregnancy because of the cyanide toxicity again. So labetalol is used to prevent maternal cerebrovascular complications. Remember this one, okay? That's that. That was with hypertension. Now with angina pectoris. Now I will close that. So this is just the classification. You should know that. We've got different types of angina and the drugs in which kind of angina are preferable. Okay. I will use this one as well. Yeah, organic nitrates. Okay, those are the simple drugs used for the relieving vasospastic angina, causing venodilation, and so on. And dilation of veins, dilation of coronaries, and this is the nitroglycerin, which has a quicker onset and but short duration of action, and so on. Adverse effects. You remember the adverse effects of the nitroglycerin and nitrates, okay? Headache. Headache is the most severe side effect. Portal hypertension, facial flushing, and tachycardia, okay? And they are contraindicated with the phosphodiesterase like PPD5s, okay? Sildenafil and denafils are not taken together with nitroglycerins, okay? If the patient are on the phosphodiesterase 5 inhibitors, we are not giving nitroglycerins, okay? Yeah, and this is how it should be. If you have a case when the patient has nocturnal, let's say, attacks of angina, then better to prescribe patches, okay, because of low duration and they can cover the night time. Beta blockers. Beta blockers here, remember, heart rate, contractility, cardiac output, they are all decreasing just like with the blood pressure, okay? Beta blockers also used for the blood pressure, arterial hypertension, but most commonly for angina pectoris, okay? Because they reduce the work of the heart and they are most beneficial with myocardial infarction patients, okay? They prolong survival, prolong survival for the patients who haven't had the myocardial infarction. Yeah, contraindications also you should know, asthma, diabetes, bradycardia, and so on. Calcium channel blockers. We mentioned with angina hypertension, with migraine, and also angina pectoris and arrhythmias. All benefit with the calcium blockers like verapamil. Mainly affects myocardial nifedipine, which peripheral vasculature, and diltiazem intermediate. Remember, okay? These three main drugs, okay? That's it. Nifedipine and diltiazem. Yeah, I want you to remember the verapamil. V. Remember, slows atrioventricular conduction. Okay, remember this one. Slows conduction. It means decreases heart rate, contractility, blood pressure, and oxygen demand as well. Okay, that's it. And sodium channel blockers like ranolazine. I will not include this one. So I will not include this one because it's uncommonly used. That was with the first part. Now let's see the second part of the cardiovascular. And kidneys are very short. The diuretic and antidiuretic. Okay, let me. Yeah. Okay. Heart failure. This is all just before reading. Yeah, these are the groups of drugs you should know. Yeah, inhibitors of renin-angiotensin system, beta blockers, diuretics, direct vasodilators, inotropic agents, aldosterone antagonists. This is you can skip all this. You can skip all this, as well as this. You can skip this. Yeah, just the signs. You should know the signs, okay? If we've got jugular vein distension, we've got hepatosplenomegaly, it means that we're left sided, right-sided conjunction, okay? In the left-sided, we've got the retention of the fluids in the lungs, okay? Pulmonary edema, it will be left-sided. But when we have a systemic circulation, like hepatosplenomegaly, edema, jugular vein distension, it means we've got right-sided peritoneal ascites as well as the cardiac cirrhosis. This is all for the right-sided, okay? The difference between left and right. So, we talked about the inhibition of renin-angiotensin system. Well, how important it is. ACE inhibitors, we talked about them. They affect the bradykinin. Okay, they know that the nitric oxide and vasodilation. Side effects, we talked about them. April is their suffix. The patients with myocardial infarction would benefit from that. Captopril and so on. Okay, Lamictal, and should never be taken with the pregnant woman because of their toxicity. Side effects were cough, the main with cough and hypokalemia as well. Taste change, renal indigestion, low blood pressure, and so on. And this is important: hypertension, congestive heart failure, myocardial infarction, prophylaxis of the cardiovascular risk, diabetic nephropathy, and scleroderma crisis. These are the indications for the ACE inhibitors. ARMS, we said that the same thing with ACs, but they have lower profile of the side effects, and they are not affecting bradykinin levels, so no vasodilation. And can be substitutes for ACs. And again, they are never used during pregnancy, okay? And sartan. Sartan is their suffix. Beta blockers, as I said, they are used for hypertension, for the angina pectoris, as well as for the heart failure, okay? especially for the heart failure, because they have negative inotropic activity, okay? Like metoprolol, long-acting, and carvedilol, the patients with myocardial infarction will benefit from this drug. And diuretics, talked many times, and we will talk about them later, okay? Side effects you should remember: hyponatremia, kalemia, magnesemia, and ototoxicity for the loop diuretics, remember, okay? Hypertension is the indication, heart failure, and edema. Okay? Pulmonary edema, if you see or hear that, you will first line treatment with diuretic, okay, with a combination of others, of course, but diuretic. Furosemide, remember furosemide. Direct vasodilators are nitrates and hydralazine. This I will not include, okay? I will not include this one as well. No. Yes, this one I said phosphodiesterase inhibitors by amrinol increases CMP and risk of associated risk with mortality. Okay. Yes, spironolactone. I will talk about this. This is the potassium steering diuretic as well, not just aldosterone antagonist, and decreases the morbidity and mortality linked with heart failure. Okay, remember that one. Okay, now arrhythmias. This is the scheme you should remember with the drugs. Okay, we've got 4 class of antiarrhythmics. The first class will be sodium channel blockers, which is divided into 3. I will not discuss all the 3. Just you should know. First A is quinidine, this one, procainamide, these 2 drugs, and first B is lidocaine, phenytoin, then maxilitine, and first C will be flecainide and propafenone. The second group is beta blockers, and we know a lot about them, like propranolol, esmolol. Third group is class 3 is the potassium channel blockers, Kalium, like amiodarone. This is the only drug I will ask from this. Amiodarone and dronedarone. Okay. Calcium channel blockers is the fourth. We are using almost in every condition in the cardiovascular system. Okay, they inhibit the calcium channels because they decrease the contractility and the cardiac demand of the oxygen. Okay, verapamil and diltiazem are the drugs. So this is not. I'm not gonna ask. About quinidine, you should know this adverse effect synchronism. Okay, remember this includes blurred vision, tinnitus, or the inappropriate and irritational, I would say, sounds in ear, headache, disorientation, and psychosis. Is accustomed with all the symptoms of the synchronism. Okay, quinidine intoxication. If they're used with the digoxin. Okay. Digoxin concentration by displacing the digoxin from the tissues. Okay. Procainamide, I said. Butalbion, I will not. And lidocaine, yes, local anesthetic, which is also used for the arrhythmias. Okay. Local anesthetic, remember. This is I will not. Class 2, we've got beta blockers. We talked too much about them. Class 3, yes, here, class 3. About class 3, you should remember about amiodarone, which is, yes, long-term, where the longest duration of action. Which drug has longest duration? Amiodarone will be your choice, okay? And it causes pulmonary, interstitial pulmonary fibrosis, just like what? Bronchriptine, okay? And interferes with the thyroid hormone function because amiodarone has iodine in its structure, okay? Hyper or hypothyroidism might occur, liver toxicity and neuropathies and blue skin. These are the adverse effects you should remember about amiodarone, okay? Which drug causes blue skin? Amiodarone. Which has the longest duration of action? Amiodarone. Which causes pulmonary fibrosis? Bronchriptine and amiodarone. And which interacts with thyroid functioning and the patients who have impaired thyroid function? also should be aware amiodarone, okay? A lot of questions can be made about. This is just skipping, calcium blockers, we know this. Verapamil therapeutics, I will skip this as well. Just verapamil, remember AV block, okay? Atrioventricular conduction is blocked with verapamil. And this is the for the cardiac emergencies. Other drugs include, and that's it. Okay, this was all about cardiovascular, and the last thing we've left is the drugs affecting kidneys. Okay, so I think I'm stressing my attention, okay, on the most important things, so it won't be as difficult as you thought, because all is there. You have just to memorize it. Yes, about glomerular filtration, I will not talk about a lot. You should know just, okay, this one is also not included, not included, not included. This is not included. Okay, yeah, classification, you should know that. Okay. High acetylene or loop diuretics, which is furosemide or furosemide. This drug, you're gonna meet at every point of heart failure. Okay, they're very quick action, and duration of action is very short. Okay. But they don't. The major side effect is the hypokalemia, hypomagnesemia, hyponatremia, and ototoxicity. Remember?
Okay, you can see the presentation.
Oh, sorry. Thank you, Marilyn. Do you see it now? Okay, thank you. So I skipped all this. You won't have a question about this. We can skip this one as well. Skip this one. Yeah, classification you should know. The drugs, and then loop diuretics. So furosemide. Remember this drug with every condition linked with heart failure. Okay, furosemide with the pulmonary edema specialist. Okay, what side effects is hypokalemia, hyponatremia, hypomagnesemia, and ototoxicity. Okay. Pulmonary edema, always with loop diuretic. Okay, remember this one. Increases calcium accretion, as I said. Bumetanide also similar, but it causes really myopathy. So side effect is myopathy, and this one I will notice. What the uses, how we use it. Edema, obviously pulmonary edema is all higher congestive heart failure. Nephrotic edema, acute pulmonary edema, as I said many times, cerebral edema for the, also furosemide can be employed with this, but also diuretics are preferable. Hypertension, we mentioned this drug, yeah, antiazid and related drugs. Thiazides also are the types of diuretics, thiazide diuretics, that when the loop diuretics are contraindicated or are not efficient, thiazides can be added. Okay. Yeah, it causes the decreased insulin release as well, hypoglycemia side effect. Okay. Edema, hypertension, again, all the time diuretics are used for edema, plus hypertension and diabetes mellitus, okay? Because thiazides are used for diabetes mellitus because they decrease glucose, yeah, reduce urine volume as well. Hypokalemia is the most common side effect of the loop and a frequent side effect for the loop diuretics and thiazide diuretics as well. Decrease of the potassium level as well. So prevented by potassium intake or the potassium sparing diuretics if we're substituted or in combination. Acute saline depletion as well, the delusional hyponatremia because diluted blood and natrium is there. GI tract and CNS disturbances, hearing loss, ototoxicity, remember this one, and allergic manifestations as well. Hyperuricemia, hyperglycemia, and hyperlipidemia is also common with mental disturbances and hepatic coma. Magnesium depletion as well. So they decrease. Yes, this is what we have already discussed. They interact with antihypertensives and in combination are very useful. Okay, they enhance digitalist toxicity and synchronism. They also increase the kinidin activity and can increase the incidence of polymorphic ventricular tachycardia due to kinidin. And neuromuscular blockers also for anemia potentiate their actions, and they cause loop directly they cause autotoxicity. As I said, that just with aminoglycosides, the autotoxicity is more severe and might cause deafness. Okay, deafness. Nephrotoxicity because again they're directly acting on the nephron and glomerulus apparatus, and aminoglycosides especially enhance their nephrotoxicity. And endometaxin, like and non-steroid anti-inflammatory drugs, diminish their actions of the diuretics. We've got anhydrase, carbonate anhydrase inhibitors, which will be after, so I will not ask a question there. Yeah, just about this. Yet, acetylcholine is used for glaucoma, for epilepsy, acute motion sickness. Okay, remember this phrase. And now calcium or potassium sparing ones. There's effects of acidosis, hypertension. I don't know this one. Potassium sparing diuretics, spironolactone. I said that about this drug. You should remember that it causes it decreases the mortality and morbidity linked with cardiac beta, linked with myocardial infarction, and so on. Okay, with cardiac arrest. So it increases the life quality and decreases mortality and morbidity. Okay. Spironolactone, as I said, yeah, for to counteract potassium loss, for edema, for hypertension, for congestive heart failure. They are used. Interactions I will not ask, and the adverse effects: drowsiness, confusion, abdominal pain, menstrual irregularities. So please remember gynecomastia and infanticide. So with very big girl, most serious hyperkalemia. Okay, they spare potassium, but they might cause the increased levels of the potassium themselves. Epinol is less osmotic diuretic mannitol. This is, remember, but it's quite widely used in neurotrauma and neurosurgery. Okay, just that one. Yeah, increase intracranial and intraocular tension. This is the indication for the mannitol. Okay, and glomerular antidiuretics. Now, all this with directly antidiuretic, we've got antidiuretic hormone, thiazide diuretics that have also antidiuretic properties. Okay, yes, vasopressin. We're going to talk about with the hypophysis and the hormones. Okay, so this is just shortly, and no, we can put this one. Yes, uterus is contracted by also acting oxytocin receptor. So this is also vasopressin analog. I will not include uses. I will include diabetes insipidus is the indication for the vasopressin usage. Okay, also bedwetting in children and nocturnia in adults. Hemophilia for Winterberg disease, vasopressin may check bleeding by releasing coagulation factors. Okay, remember this part. important hemophilia, and Wilbrand with vasopressin, and also esophagus bleeding for the esophageal varices. Okay, vasopressin and terlipressin stop the bleeding by constricting mesenteric blood vessels and reducing blood flow. The first effort is the bleeding, headache, flushing, epistaxis bleeding from nose, because they are most of the vasopressin, desmopressin, they are suppositions nasal drops. Okay, so that is why bleeding from the nose might occur. With retention and hyponatremia, because antidiuretics, they increase the retention of the sodium and the fluid. And thiazides, these are the diuretics that have also antidiuretic property. Yeah, you know that. Which are the diuretics that have antidiuretic property? Thiazides, okay? Like amyloid is the drug of the choice for lithium-induced diabetes insipidus. Remember, amyloid is for the lithium-induced nephrogenic diabetes insipidus. Remember this one. And indomethacin for the renal diabetes insipidus and reducing renal protagonist synthesis. And that's quite it what I wanted to review with you today. All three topics. The rest three topics, hormones, drugs affecting blood, and gastrointestinal, we're gonna review on Saturday, okay? And next week you're gonna have a midterm. Don't be scared. Just be prepared, okay? Read the book and then rewatch the lectures if you, okay? Yeah, no, it's too big, but it's not going to be easy. As I said that I warned you about that because it's a lot. It's a lot of systems. It's 10 chapters. I know, but the PPTs and lectures will help you to summarize. Okay? Yeah, it will not be. If you unless you read it, okay? If you read it, it will be just as easy as the first one, okay? If you read it, if you watch the videos, it's gonna be easy, okay? But not as easy as the first one. I know, Yusuf, don't worry. Yes, no. Okay. Okay. If you will be prepared, if you do as I said, you will definitely pass and get a high score. So don't worry, worrying will get you nothing. Don't complain, just don't waste your time and read it, okay? Okay, that was it. I will let you free now. You can go on rest and then read the book, okay? Please read at least 3 chapters we reviewed today, okay? Thank you very much. Thank you, Philip. Thank you, Marilyn. Thank you, Yusuf. Thank you, Sarah. Thank you for being here, listening, and see you on Saturday. Good luck, okay? Don't waste your time. Just read, okay? If you read it, it's gonna be okay. Bye-bye. See you. Bye-bye.